other areas like creating blood clots and just a variety of tumors when it comes to the paraneoplastic syndromes. So, what do we do when we identify these signs, symptoms, and syndromes? What are we supposed to do? Well, whenever you're doing your full medical history and you're getting your physical exam, you want to assess and check for risk factors. So, you want to ask questions, open ended questions, especially if they've had any potential exposures to any of those that increase the risk for lung cancer. And not only while we're doing our assessment and doing our getting our medical history, we want to start thinking about additional diagnostics when it comes to lung cancer. So, those diagnostics that we're going to think about are to identify suspicious areas in the lungs. So, a lot of times when we get a patient that has shortness of breath, they may end up with a chest x ray. And we may see something on the chest x ray that leads us down the path of, oh, we need to look at that a little bit further. If we do identify that the patient does have some sort of neoplasm, then we need to identify if and where that cancer has spread. We need to start getting these patients on some sort of therapy, some sort of regimen, so that we can evaluate the effectiveness of that treatment and we can assess the signs that cancer has returned post intervention or that patient's had a relapse. So, once they go into remission, or if they go into remission, it doesn't mean that they are completely cancer free. I take that back. They are cancer free, but it doesn't mean that the cancer won't come back and it won't spread. So, some of the things that we're going to look at imaging. We're going to start to identify what some of the um, cancers are, and we can do some analysis when it comes to the different types of cancer that are out there. So, we've got 5 different types of imaging that we can use. Like I said, this typically going to start with a chest x ray, and you're going to see something, and it's like, that's not supposed to be there. Then we're going to get a CT. That CT could lead to a PET scan or an MRI and even a bone scan. So, these 3 down here are going to be if and when the CT is confirming a diagnosis of lung cancer. When we look at identification, we can look at sputum cytology, so we can have that patient cough up a sputum and we'll take that sputum down to the lab and we'll do some testing on it. Bronchoscopy, this is a needle biopsy or a brushing biopsy. In the bronchoscope, there is what's called a working channel. That working channel is an open port to the distal end of that bronchoscope. So you can see through the camera your little brushes or your little tools so that you can grab and pinch the foreign cells and then pull that back through the bronchoscope and get a sample. There's what's called an EBUS or an endobronchial ultrasound. This is an endoscopic esophageal ultrasound, basically where we send it looks like a bronchoscope, but a bronchoscope down the airways and it sends ultrasound waves so that we can see what's going on. Very similar to what we have with our ultrasound wand, with what we can use for vascular access or point of care ultrasound looking at the lung scanning using the blue protocol. But the EBUS is like a bronchoscope that sends ultrasound signals. We can do a thoracentesis. We can do that video assisted thoracic surgery. Remember, that's that teeny tiny microscopic incision so that we can get that peripheral abnormal cell growth. Then there's analysis. You've got the immunohistochemistry that we can do. We can do a molecular test and we can look at the CBC. So, a number of different tests when it comes to diagnosing cancer. So, remember, we have this space occupying tumor, this space occupying lesion that is deboing this neighborhood. It's deboing this area. And you're going to end up with atelectasis. You're going to end up with increased bronchial secretions. So, what do you think that does to oxygenation? Breathe more, beat more, hypoxemia, right? What's your lung compliance going to look like if you have these tumors and cavitations in the airway? Yeah, your compliance is going to go down, or they're going to have potential pain, anxiety. They're going to have a tracheal shift. There could be large airway shift. They can have cyanosis. They're going to be hypertensive, tachycardic. You're going to have dry, non-productive coughs to a productive cough that has hemoptysis. You could have crackles. You could have wheezes. Those crackles could be fine if it's fluid. It could be coarse if it's consolidation. When you look at ABGs, if you have a localized or a lobar lung cancer, then that would look like an impending ventilatory failure. If you have a widespread look at the tumors have spread out, then you could end up with acute ventilatory failure. And then this will impact our hemodynamics as well. We already started talking about the ABG, if it's localized versus widespread. Again, acute alveolar hyperventilation versus acute ventilatory failure. Your oxygen indices, how is this going to impact your shunt? How is it going to impact your delivery of oxygen? How is it going to impact your oxygen consumption? The difference between your arterial and venous oxygen, the exchange ratio, and what's going to be left over at the end. When you look at these patients, they're going to end up with hypoxemia and acidemia. They're going to be hypercarbic, so that's going to increase your PVR. All of that's going to increase all of the pressures on the right. When we look at other downsides to lung cancer, is it is a space occupying lesion. It is going to take over, and it doesn't matter if the heart is supposed to be in this area. It will take over the mediastinum. If it takes over the mediastinum, that will impact all of the hemodynamics, not just what's on the right side. And we can end up with SVC, or superior vena cava compression, meaning we're not getting blood back into the right atrium, and all that blood's going to back up into the superior vena cava, into the subclavian vein, to the internal jugular vein, and lead to a swelling. When we look at the pulmonary function testing, these poor patients are going to have decreased flows and decreased capacities. So they're going to have obstructive disorders and they're going to have restrictive disorders. So lots of chaos when it comes to these neoplasms. When we look at the chest x-ray, you're going to see small or coin lesions. Sometimes these can be large irregular masses, but we're going to see alveolar consolidation, atelectasis, even pleural effusions. So here you can see this massive circular or coin or oval shaped lesion that's in the chest x-ray. This right here would give me more reason to want to investigate further. Like, what is that? We need a better picture, and we need to get some identification as to what that guy is so that we can get this patient on the right treatment plan. Sometimes you have lung cancers that hide behind the cardiac silhouette, and you can see here that we have the lungs. They have a haziness to them. There's a consolidation to them, and we can see there's a small coin-like or a circular lesion here, and then there's one that's hiding here behind the heart. Well, this one here that doesn't have anything blocking it, I can see that pretty well. But this one that's behind the heart, I would need to investigate further. So whenever I investigate further, the next step up would be to do a CAT scan. And whenever I do a CAT scan, this circular lesion that's behind the heart is what this is here in the CAT scan. So we're able to see with more clarity what that means, because if I think about it, the CAT scan is almost like a ruler. And the CAT scan, what it does is it spins super fast around that patient. And it will cut the patient into centimeters or even millimeters. When it does that, we can take out a slice of that image, almost like a loaf of bread. We've got a loaf of bread and we can pull out an individual slice. That's what it's like looking at a CAT scan. So when we look at CAT scans, it's taking an individual slice out of this entire loaf of bread. So here I have this foreign opacity behind the heart that I needed more information on. I got the CAT scan and I can see this lesion here in the left lower lobe. If we're still a little unsure about what's going on when these patients presents, we can do what's called a PET scan or a positron emission tomography. It sounds kind of like a transformer, this positron emission tomography. Just nerding out a little bit, but don't mind me. Anyways, you can use this to confirm those suspicious spots. And this is a form of nuclear medicine where these patients are injected with radioactive dye and they're sent through this scan to identify if they have any quote unquote hotspot. This is a very, very good way for us to get very specific answers with high quality imaging to know exactly what those things are. So a PET scan is like let's highlight this for lung cancer diagnostics. The last thing that we could have here is direct visualization. So whenever I'm doing a bronchoscopy, if I see a tumor during a bronch, then hello, then that thing is a tumor. So we can have direct visualization as another diagnostic when we are performing a bronchoscopy. Not only is it used for therapeutic and diagnostic, we need to be aware and situationally and environmentally aware of what we're seeing so that we do not miss a potential tumor. So when we get into the treatments of this, we already started kind of talking about it with the surgical interventions, some of the chemo, some of the radiations, and I kind of just highlighted some of those radiations, and we're going to jump into those a little bit more. So these radiations, these are the EBRT, the 3D CRT, the IMRT, SBRT, the SRS, and what's called brachial therapy. These are all different forms of radiation. When we look at the EBRT, this is our most common. This is our most common use of radiation, and these patients are getting radiation 5 days a week for 5 to 7 weeks. So when we look at these 3D CRTs, these are designed to do mapping of the tumors. And radiation beams come from all different directions so that we can get a 3D image of where that tumor is exactly. Then there's what's called the intensity modulated radiation therapy, or the IMRT. This is more advanced than even the 3D CRT. So with this one, the intensity can actually be adjusted. Then we have the SBRT. This is very focused, high dose beams and fewer treatments. So this is like I can precisely see that tumor, and I'm going to use these radiation beams to shoot them to try to destroy those. Typically, because the dosing is so high, they don't need as many treatments. But we can use this for small tumors, and there's very, very, very few risks with complications when it comes to the SBRT. When we look at the SRS, this is a conjunctive therapy with the SBRT that's done as only one session. When we look at the brachial therapy, this is internal radiation, and we're actually having the patients have pellets placed directly into the tumor via a bronchoscope. So lots of different potentials and opportunities when it comes to radiation. I would definitely know and be able to differentiate the 6 different types of radiation here. So when we look at chemotherapy, there are a couple of different ways that we can do chemotherapy and we can target our chemotherapy. We can do it as a before surgery, adjunctive therapy, conjunctive therapy, and a primary therapy. So these two are very similar, but they have 2 different targets. Okay, both of these happen before surgery. Before surgery and adjunctive are both before surgery. The difference is before surgery, what we're trying to do is we're trying to shrink the tumors. When we look at adjunctive therapy, we're actually trying to kill the foreign cells before surgery. So before surgery and adjunctive, both of them take place before surgery, but this one is designed to kill and this one's designed to shrink. When we look at conjunctive therapy, with conjunctive therapy, what we're talking about is using chemotherapy when radiation isn't enough. So we're getting radiation therapy plus chemotherapy equals conjunctive therapy. And then we can look at primary therapy. When we look at primary therapy, this can also be along with radiation, but this is what's going to take place when the patients are too weak for surgery. So the primary therapy is going to be way more for those that are too weak for surgery and simply getting chemo and radiation as primary therapy. So when we look here, these are all the different types of chemotherapy. I'm not going to create a list and make you memorize it. Just know that there are a number of different therapies or chemotherapies that are available when it comes to that intervention. But we know that there's some complications that are associated with chemotherapy. The one that we're probably most familiar with is hair loss. Back in 2021, I actually shaved my head. I've gone through a couple of different hairstyles. I've shaved my head so that my dad, who was going through chemotherapy at the time, he didn't feel left out. So hair loss is part of chemotherapy. Got a really good picture of him without hair. It was just hilarious. Not only that, but you end up with mouth sores. And sometimes you end up losing your teeth because the mouth sores are so bad. So a lot of times these patients will end up with um, a specific like toothpaste and a specific mouth wash that they use to prevent these mouth sores. They don't want to eat. There's a loss of appetite. There's normal nausea and vomiting, diarrhea, or constipation. So they can be plugged up or they can be loose as a goose. You got an increased risk of infection because our white blood cells are decreased. These patients are going to be easily bruised or easily bleeding because it'll impact their platelets and their clotting factor. And then they're going to end up with fatigue because the red blood cells are impacted as well. So some of these we may be familiar with the hair loss of appetite, not loss of appetite, loss of appetite, and nausea and vomiting. I think these three are pretty common and well-known side effects to chemotherapy, but we need to be well abreast of all of the different side effects of chemo. Then we have what's called drug-targeted therapies, and these are different therapies that we use for lung cancer. So when we look at this, we have one, two, three, four different types of targeted drug therapies, and what these do is they are designed to obliterate or eliminate the blood supply to the tumors. That's all essentially what they're designed to. They're designed to shrink and starve out those tumors. It's almost like we figured out a way to do some like warfare almost against these tumors because they have a blood supply that feeds them. When they get that blood supply, they're able to proliferate and multiply. But if we can choke out their blood supply using these different targeted drug therapies, then we can shrink those tumors and we decrease the likelihood that they will grow and spread. Lastly, here, these are things that we are very well familiar with. These patients are going to need some oxygen. They're going to have extensive secretions. They're going to have atelectasis. We're going to need to aerosolize some medications, whether that's SABAs, LABAs, anti-inflammatory medications, even antibiotics we're going to see. These patients are going to end up on different um, modes of mechanical ventilation, whether that's invasive or non-invasive. We're even seeing that even some high flow nasal cannula can impact the ability for type 2 ventilatory failure. What was type 2 again? And what's type 1 ventilatory failure? Go back and remember those things because those are specific. But ultimately, we can end up with patients that are in type 2 ventilatory failure that's irreversible. And these patients are going to have a lifetime on mechanical ventilation, or they're ultimately going to succumb to this disease and, and pass. But we do everything that we possibly can to educate them, to treat them, to make sure that they can breathe just a little bit easier today. That is my job, is to help you breathe a little bit easier. And what your job is right now is to learn how to help these patients breathe a little bit easier. So my job isn't necessarily to help these patients breathe a little bit easier anymore. My job now is to help you learn how to navigate the ways and the paths and the waters to help these patients breathe a little bit easier. So we just need to know what we need to know when it comes to lung cancer, all the different types, whether it's small cell carcinoma or non-small cell carcinoma, which ones are associated with smoking, which ones aren't, which ones will respond to chemo, which ones won't, which ones respond to surgery, which ones won't, what are our diagnostics that we can do, how do we treat these patients so that they can ultimately breathe one day a little bit easier. That's what we've got when it comes to lung cancer. We will be back for sleep disorders in our next lecture.